What's going on, everybody? Purpose of this video is to take a little bit of a look into how to approach extubation. Going to look at a few things within this video here. We're going to take a look at assessing readiness. All right, so how to know if somebody's ready to extubate in the first place. We're going to look at this with the understanding that more is going to come as we progress on our ventilation courses, as well as you formally talk about extubation in your airway management lecture. But we're going to take a look at some things we can quickly assess at the bedside. We're going to talk, in regards to assessing readiness, there's a contingent subject called the cuff leak test, a test we can do to try and see if we think that patient's upper airway is swollen, subglottic edema that might lead to post-extubation problems such as stridor, need for reintubation. There's been some new data that's come out actually as recent as last month, so we're going to kind of take a look into that, and then we're actually going to look at the process of truly extubating a patient here. Okay, so as far as assessing readiness, a good, basic, easy question you can ask yourself is that patient's underlying cause, is it resolved? If we just intubated this patient overnight and they still have a raging infection that's given the same problems with gas exchange as they had initially, all right, and things aren't markedly better, they're probably not ready. All right, so it's going to be kind of individualized. So it's one of the first things I take a look at. Next thing, we got to think about things from a respiratory therapist perspective and gas exchange, okay? Can my patient adequately ventilate if I pull that tube out? And are they going to be able to sufficiently oxygenate if I pull that tube out? All right, two very separate things we're going to kind of take a look at. So in regards to ventilation, we know they're on the ventilator. Ideally, they've had a pause or a major weaning of their sedation, and they can actually initiate breaths, okay? They have a good, stable ventilatory drive. We'll talk about what else they should be able to do from a sedation weaning perspective and being awake and things like that here lastly. So for us, from a ventilation perspective, we want to make sure this patient can maintain an appropriate rate and tidal volume, all right, sufficient with normal respiratory acid base, okay? So can they sustain effective minute ventilation without needing a whole lot of help from the ventilator, okay? We could have a patient breathing on their own but getting a substantial amount of help from the ventilator. Well, when we extubate them, they may not get that. They're not going to get that help unless we use non-invasive or something like that. So when I refer to can they maintain an appropriate minute ventilation, we usually evaluate this a couple of different ways, but most of us prefer to look at something called an SBT, or a spontaneous breathing trial. It's allowing this patient's sedation to be let up, let them wake up a little bit, and placing them on low level of respiratory assistance or ventilatory assistance, okay? So there's a couple of things we can do with that. Tried and true is low level pressure support, so 5 of pressure support on top of 5 of PEEP, so a total of 10 centimeters inspiratory pressure, all right? So that's kind of the tried and true. Not that we can't extubate somebody for more than that, okay? But there's some other variables there. If they're getting a substantial amount of support, that may mask how well they might do when we take away that support with extubation. Another option you can do is there's something called artificial airway compensation, automatic tube compensation. Goes by a lot of different terms and abbreviations, but ultimately that's an option. Some people refer to it as electronic extubation. It allows us to really apply enough inspiratory assistance and expiratory assistance to a certain extent to compensate for the level of resistance imposed by the ET tube itself, which we know most people is about 5 to 10 centimeters of water per liter per second. The thing is, with that equation, that amount of resistance imposed by that tube, as our flow changes, we'll see the amount of pressure it takes to overcome that resistance kind of change, all right? So when we just add on pressure support by itself to help overcome that resistance, sometimes we might be overcompensating. Low flow states, as a patient starts really sucking flow, though, we might be undercompensating. Automatic tube compensation or artificial airway comp, whatever you want to call it, it provides that level of inspiratory assistance proportional to the amount of flow rate going through that tube, okay? So it gives us the best idea of how that patient might do after extubation. Now, there's not a lot of data supporting that, all right, but it is an option some people use. Some people use that in conjunction with low-level pressure support, which, that's okay, but you got to take a look and see how much inspiratory assistance they're really getting. It's really double dipping. You're giving them pressure support to help, add inspiratory assistance to the respiratory system, where at the same time you're also adding this additional pressure that's manifested through this tube comp, okay? So you got to take a look and see what your peak pressure is on the ventilator readout, and you might see that you might only have 5 of support, but if you have this tubing or the airway compensation feature on, you might be given a lot more than what you actually think. So pay attention to your peak pressure and your baseline, and think about how much inspiratory help they're really getting. The gold standard, and there's some different things we do to evaluate when we first transition them over to make sure that we should continue on with this spontaneous breathing trial, but we'll get into that stuff later. Once they're doing good, they can get a good tidal volume, good minute ventilation, good respiratory rate. All right, we usually let them go for about 30 minutes. Now, it's not uncommon to see their tidal volume be a little bit lower. On low-level support or just tube comp by itself, we generally like to see somebody be able to achieve about a 4 mil per kilo tidal volume or better. All right, we like to see that respiratory rate and work of breathing really staying beneath that 30, sometimes briefly if they shoot up above 30 a little bit, that's okay, but we might take a hard look at that before we approach extubation. All right, another thing we take a look at, there's an indice called the RSBI. It looks at your frequency relative to your tidal volume in liters. All right, this vent just calls it, you got it in a couple different places, it says RSB. You'll see F over VT on your 980s and 840s and stuff like that. And that is a good weaning indice depending on who you talk to and what data you're looking at. But generally, the lower the number, the better, and the more sustainable it is. We still got to look at the big picture. It's just one number, all right? So less than 105 is usually pretty consistent with successful, ventilator liberation and not needing the vent passing this trial. Once again, you got to look at the big picture, though. You could have a insufficient minute ventilation and still have a good RSBI. So that's something you'll hear people talk about. This vent is pretty cool. It gives you this little vent status parameter here, and it takes a look, and there's certain criteria where if they meet this in a spontaneous mode of ventilation, which I had this patient on just pressure support of 5 and PEEP 5 right now, if they are maintaining certain parameters, so not requiring too much peak pressure, the RSBI is good, minute volume's good, they're breathing all, their breaths are spontaneous, okay, it's going to start a timer. So vision's a little blurry probably through the screen, but you can see this about 6 minutes. So I want to see this patient doing well still at the end of 30 minutes, all right? So that's looking at ventilation. Sometimes people get a blood gas at the end, sometimes we don't. It just kind of depends on the situation. There's not a true right or wrong all the time. The other thing is oxygenation. I generally want to see my patient be able to have a sufficient PaO2 or really, SpO2 with an FiO2 of 40% or less and not requiring a substantial amount of PEEP. So most places I've worked, you want to see them down to a PEEP of 5. Some places we want to see them down to a PEEP of 8. Kind of depends, but we don't want somebody on a PEEP of 14 or something like that generally for us to be able to extubate them. Otherwise, I'm going to run into some trouble with oxygenation when I remove them and I start talking, extubation and non-invasive and all these other things here. So I got this patient on a PEEP of 5 and 35%. That's pretty good. All right, when you think about below 40, that really is attainable with a nasal cannula, although there's lots of other different options we can incorporate if we choose to do so. So oxygenation looks good there. All right, the other thing you want to think about is hemodynamic stability. So is this patient requiring a lot of vasopressors or, cardiogenic kind of drugs and things like that? If they are, there's a good chance that by removing that ventilatory assistance for them or putting more on the respiratory system, it could kind of throw their whole rest of their body for a loop and put more stress on the heart and everything like that. So sometimes we'll pump the brakes. You might encounter situations where you extubate somebody on a little bit of some vasoactive drugs, things like that. Kind of depends on the situation. Another one is airway protection, okay? So can this patient protect their airway? I'm not just going to go back and gag them or anything, although that is going to be part of it as we go through here. Usually a good approach that most therapists use is a patient able to kind of be awake and somewhat alert? Can they track you in the room? Can they follow some basic commands? Thumbs up, squeeze my fingers, lifting the head up off the pillow is a good sign there. All right, that's only part of it. I also want to make sure that they have a good strong cough with suction and that we haven't been having to suction them out a whole lot, okay? Somebody might be doing well on the ventilator and breathing on their own and oxygenating okay because we have direct access down there and we're pulling those secretions out. If they're making a ton of secretions and or don't have a good effective cough, we might run into some problems afterwards and we might want to pump the brakes on that extubation a little bit. All right, so if somebody is awake and alert, got a good strong cough, not making a ton of secretions and requiring frequent suction, those are usually pretty good signs that we could consider moving forward with extubation there. So, or at least evaluating them for extubation, okay? So we're going to take a look at another thing here called the cuff leak test. And what is difficult to assess is if this patient has been intubated for a long period of time, I worked at a place where they're not checking cuff pressures and they're sky high, they're difficult intubation, or even, women, they're more likely to have some issues with upper airway swelling or subglottic edema when we remove this tube. Right now, their airway could be completely swollen and clenched down on that tube, and I have no idea if I just go ahead and deflate the cuff and extubate this patient, because that tube is keeping things patent. So what we've been looking for is a way to assess how likely it is this patient might have some issues post-extubation here. So the cuff leak test is something that involves actually deflating the cuff and making sure that if I deflate the cuff, that air is coming from the ventilator down in the tracheobronchial tree, but whenever it's exhaled, it's going to go up and past the ET tube. We want to see the presence of a leak. Now, some people I've worked with give me a hard time about not doing a cuff leak test on certain people, but when they do a cuff leak test, they do what's called a qualitative, meaning just listen, do they have a leak? If they heard a leak, they're good. Well, that leak might have been 2 mils, and there's nothing to support that that's suggestive of anything at all. A quantitative cuff leak is one that we actually look at the VTI, or the tidal volume delivered through the ET tube, versus VTE, the amount that gets exhaled goes back through the tube and back to the ventilator. The idea is if we have a complete swelling of that glottis, everything's going to be tight on the tube. Even though we deflate the cuff, there's still enough of a seal there that a majority of that air is going to come back through the tube and thus back to the ventilator. If you don't have a remarkable amount of swelling when we deflate that cuff, gas will go in, but it's not going to come back up through the tube. It's going to go up and around it. All right. Now, the problem was there's been poor predictive power on some of this stuff throughout the years. Sometimes, we'd have situations where people would pass the cuff leak test but still have problems and get re-intubated and things like that. But it's come a long way, all right? A study a few years back shows that if you had a situation where you didn't have a sufficient cuff leak, and we'll talk about what sufficient is, you were more than likely going to have some trouble. It was a good job predicting that you might have some difficulty. What it was poor at was people that passed could still have problems. So just because you passed a cuff leak test didn't mean that you were in the clear. There's a study that came out last month by Rich Collette out from the West Coast and some of his colleagues, and they looked at this over, I think, the course of 6 years, and what they came up with is a cuff leak less than 110 mils is suggestive of potential complications of post-extubation stridor and swelling. A cuff leak greater than 110 mils is suggestive that you are less likely to run into problems and have issues with subglottic edema after extubation. All right. Now, nothing's 100%, but this had a pretty good predictive power. They even looked at the feasibility of using 100 mils as a cutoff, and it still had a pretty good predictive power there. So what that means is whenever I deflate this cuff, the routine value that we're seeing on the ventilator is VTE, exhaled tidal volume. That's the amount that's coming back through the vent. I'd like to see more than 110 mils disparity between the tidal volume delivered and the tidal volume exhaled. You can switch a patient over to volume control if it makes it a little more simple for you. You can also look at the monitoring and try and get an idea. And in all these vents, show you VTI and VTE. On this vent, it's monitoring. On the 980, 840, I think you got to hit the pull down a couple of times and get kind of some drop downs to be able to find that. The 840, you had to hit a little clipboard on the screen and show you all those things. So volume sometimes is the easiest because dropping that cuff can cause a little bit of some disparity in your numbers here. But I just kind of take a look at your VTI and VTE. Before we proceed forward with anything, okay, part of your initial assessment, you're going to do your baseline assessment. How's this patient sound? Listen to breath sounds, all this different stuff. Okay, try and get an understanding of what their baseline might be in case you have any sort of trouble or anything like that. I'm going to go down and suction this guy just a little bit beforehand here, a little bit of stuff rumbling. I'm going to silence the alarms, 100% O2 here, and I'm going to go down and suction. So I already got my vacuum set appropriately, less than 200 millimeter mercury max. I'm hooked up here. I want to make sure that my vacuum button is not locked. Okay, if it is, just twist it until it's nice and pressable. I'm going to go ahead and let this patient know that I'm going to go down and suction them out here a little bit. I'm going to watch the monitor. All right, going to be a big cough here, buddy. Going to go down and get some stuff out. I kind of quickly get down, but then slow down as I'm getting close to the end of the tube. Go until I meet a little bit of resistance or cough. Pull back about a centimeter, and then lay on that suction. I'm watching the vitals, all right, and I'm kind of laying on that for no more than 15 seconds. Once I feel like I'm done getting stuff out, I'm going to go ahead and pull that back out, let off the suction, and I'm good. I could let him kind of recuperate and see if I need to go down again. He's pretty good here. I'm going to go ahead next, before I proceed with this cuff leak test, I'm going to go ahead and suck out things on top of the cuff. So I'm going to clear his oropharynx. Going to be a little bit of a gag. Going to get some stuff out of the back of your throat here, buddy. get all that stuff out and kind of let him recoup. If you had some real thick stuff, usually we'll have 2 separate suction lines. I just got one here in our lab. You could turn up your vacuum a little bit more. All right, so at this point, we're still not sure if we're going to do an extubation. I'm checking this cuff leak, okay? Typically what I'll do is I won't do this till the end of that patient's spontaneous breathing trial, till that 30 minutes, and we already know we're going to proceed with some stuff, and this might be something that the physician wants you to do. Some places we do this on everybody. It really depends on the situation. I don't necessarily do it on everybody, although I should. It's more if I know you're a difficult airway, been on the vent for a long time, or you're not doing cuff pressures routinely. If you're a female, I know you're a little bit more risk there. So I've already suctioned them out. All right, got all that stuff off the top of the cuff. What I'm going to do, I'm going to let them know there's going to be a little tickle in his throat. I'm just going to look at something. All right, what I'm going to look at here, I pull up the monitoring tab. You can see I'm giving about 380 mils. I want to see at least 110 less than that coming back when I deflate this cuff, okay, fully deflating the cuff. So if we can get down to at least 270, that's a borderline pass there in regards to not being major swelling. So I'm going to drop that cuff entirely, all right, and we're going to kind of take a look. It's going to take a breath here. Hold on. 165. A lot of times I'll try and do a 2 or 3 breath average if I'm having trouble getting a consistent measure. So you can see, I don't know if you can see the numbers, we dropped down to about 165 mils, so that's much more than 110 milliliter volume disparity, so we would be good there. They passed this cuff leak test, all right? Now, the nomenclature with this gets a little bit tricky. What's a positive cuff leak test versus a negative? Technically, that's referred to as a negative. I try not to use that term because it confuses residents and other therapists. I just say they do have a cuff leak test. They passed the cuff leak test. Positive cuff leak test means they don't have sufficient leak, and we're worried about post-extubation stridor. So he passed this. I could go ahead, talk to the physician and everything like that. Once I got an order to extubate, we can kind of proceed forward. So they're still on their spontaneous breathing trial at this point. What I want to do is kind of get them prepared. All right, and just to be clear, I did put that cuff up as soon as I was done with that cuff leak test. I like to make friends with my nurse and make sure that I put like a towel or a sheet or a chuck or something like that over my patient's chest, because things might get a little bit messy, and I don't want to mess up their gown and put more work on our bedside nurse or anything like that. I also want to get this patient sitting up nice and tall. So get him sitting as high fowlers as possible. Our whole approach to how we do this procedure is to try and mitigate any sort of risk of any additional stuff on top of the cuff draining back down and into the lung. So setting him up nice and tall is going to let him take a deep breath, have a good strong cough out. It's going to help him kind of protect his airway a little bit more as we kind of approach this. Oxygen, I got this guy on 35% and a PEEP of 5, so I just get an appropriate oxygen device. So if you think about it, 4-liter nasal cannula ought to put us about at the same FiO2. I can start at 4. If some people start at 5 or 6 and just quickly wean down. We are losing a little bit of that PEEP, so we can kind of consider that. And I just kind of leave that hanging and ready to roll. I already got my Yankar, and I already suctioned because I did a cuff leak test. Sometimes you're not doing a cuff leak test, and you got to repeat these steps, and we're going to do that anyways. So I got that here. A lot of times I'll have my nurse help me and man the Yankars. I kind of pull the tube and everything like that. So now that I got everything kind of set up, I'm going to tell you something I do, not everybody does. This is a study some years back, and it resonated with me, being very conscientious about what I can do to prevent any sort of additional stuff on top of that cuff from draining down in the tracheobronchial tree. I was always looking at different ways to make sure that doesn't happen, especially coming from a therapist that I did not routinely do a cuff leak test on all my adult patients, all right? So I might still have a little bit of stuff on top of there, and the only first time I'm deflating the cuff is when I'm pulling the tube here. So one thing I generally do is I will go up on the pressure support just a little bit as I prepare for this. It lets them kind of get some nice big deep breaths, and the idea is whenever I go to deflate that, they have a little bit more pressure in their chest that's going to shoot air up and around their cuff. So you want to be conscientious about their tidal volume. I don't want this guy to be getting 8 and 10 mil per kilo, but I want to make sure he's getting appropriate tidal volumes. My little lung model here, the tidal volumes are going to go way up as I increase this, but a real patient, they may not be putting forth as much effort and things like that. So I do this, all right. I'm going to still go down and do suction above and below the cuff here again, just to make sure. So I'm going to go ahead and get some more stuff out of the back of the throat here. Get really far back, make sure we get it all, especially if you haven't done the cuff leak test already. Since I just did a cuff leak test on him, we should be good. So I'm going to go down and suction below the cuff again. So I'm going to 100% O2 this patient. I'd probably do that a moment ago, give him a little bit more of a buffer before I go down. I'm going to go down in kind of flash speed. All right, big cough. You can see I'm supporting the tube and kind of do my push-pull. Big cough. Pull back a little bit. Lay on that. Continue to suck them out. Let them kind of recuperate here. Switch back over to my Yankar. So, I'm going to leave him still on this 100%, okay, because there's a chance I could pull the tube, even though he passes cuff leak, and his airway swells off, and I run into some trouble. So this just ensures that I'm giving him a sufficient amount of oxygen down there. I get a little bit of a buffer here, okay? So what we're going to kind of do at this point, I prefer to get about a 12 mil syringe, and I go ahead and hook it up to the pilot balloon, but I'm not going to do anything yet. I already got this guy sitting up nice and tall. I got my oxygen device ready. I got my vent settings kind of bumped up here a little bit. I'm going to undo my tube holder, but I'm not actually going to, forget about maintaining that security. I've seen videos where people undo this and the patient's sitting there with a tube in their throat. That cuff seals the airway. It's not meant to stabilize it or anything. You don't want that cuff or that tube to come out with the cuff up and mess up their vocal cords. So I go ahead and peel the adhesive off. I'm still kind of maintaining here. And what I'm going to do, all right, once again, I'm going to have the nurse kind of stand and help me here with this. I prefer to do all the cuff drop and everything like that. I'm going to give this patient some instructions, and then we're going to proceed forward, okay? And what we're trying to do, I tell him, all right, buddy, when I tell you, I'm going to have you take a big, deep breath in, deep of a breath as you possibly can take. You're going to feel a little tickle in your throat. And when I pull that tube, big, strong cough out. The idea is if we deflate that cuff at peak inspiration, that patient's going to have a total of 15 centimeters of pressure inside of their chest. Their lungs are filled up. The only way air can go is out. If I deflate the cuff at peak inspiration, that pressure is going to shoot any sort of residual secretions on top of that cuff up and out. If I wasn't paying attention and I deflated the cuff when their diaphragm's pulling down, they could potentially suck that stuff down off the cuff, okay? So we're trying to big, deep breath in, drop the cuff when the lungs are filled up on an end inspiration, and quickly pull out following the normal curvature of the airway. Now, I didn't use a lot of lube when I was intubating this patient, so this patient well, the tube might hang up. On a real patient, it comes out rather easy, okay? So once again, I'd have a nurse kind of helping me with this. I'm going to kind of do it solo. The other thing I want to make sure I'm doing is I'm right next to the ventilator. I want to go ahead and hit standby on that very quickly so I'm not getting sprayed. I'm probably wearing eye protection and stuff like that. So if I'm right here, usually if I'm not looking at a video, I'm watching their chest. This guy, you can't see chest res on him, so I'd be watching the graphics. But I go ahead and they'd follow commands, okay? So big deep breath in. All right, big deep breath. Big cough out. And I go ahead and pull it. Once again, no lube there. Cough, cough, cough. Keep coughing. I stand by the ventilator so it's not spraying. I put everything on the sheet so it doesn't make a mess. Cough, cough, cough. There you go. Get all that stuff out. Keep taking the big deep breaths and coughing. We'll go ahead and put you on a little bit of oxygen here real quick, buddy. So I just got him on 4 liters. Slip that back behind the ears here. Get him snugged up. All right. I usually ask him to try and say something. Their voice might be a little hoarse for a moment here. All right. But it should get a little bit better usually. Does that feel better? How do you like that? I go ahead and wrap up all this stuff, and usually I'll put this in like a biohazard bin or something like that instead of regular trash cans, so you see like red trash bags, red trash cans in those rooms in the ICU. Give them their little Yankar here and encourage them to keep kind of coughing. Put my ventilator circuit out of the way here. All right, let's do a quick little assessment. All right, big deep breaths in and out. I'm making sure he's moving sufficient tidal volume. No adventitious breath sounds or anything kind of concerning. I'm looking at his respiratory rate and pattern and work of breathing and things like that. I had on one additional spot, and that's listening to the side of the larynx, so right here. And I'm just listening for stridor, okay? So if this patient had a little bit of some mild stridor and I noticed some problems and work of breathing is nothing too crazy, I could try a little bit of some racemic epi, give him small volume neb. I run on a little bit of a lower flow, get those bigger particle sizes, try and get them kind of depositing up top, all right, and kind of monitor it. You could consider cool mist and things like that. As the patient starts getting more significant trouble, the tendencies for some physicians and other therapists to be to slap them on non-invasive or an OptiFlow. It can kind of help if you got a little bit of swelling. The problem is if you have significant swelling, significant stridor, significant problems, it can kind of mask that until it's too late. and then they end up getting cracked. So if I have a patient that goes into tremendous stridor right away with evident, trouble with ventilation, work of breathing, point of poor air movement, poor oxygenation, I'll usually opt for re-intubating them. And as you're extubating somebody, you should always know where you should still have a resuscitator, you should know where your re-intubation supplies are, you already got your order. But being very, very cautious, even when you have a cuff leak test, and they pass that, they can still run into some problems, okay? So don't be all willy-nilly and beating around the bush if they go into severe stridor. Sometimes they need to be re-intubated while we still have time if that airway's swelling up here, all right? So I kind of clean up my mess. A lot of times I'll put a cap on my ventilator circuit or put a glove or something like that. Depending on the situation, I might leave the ventilator in the room on standby. Okay, if you're running heated humidification, make sure you turn your heater off. Now there's not air going through, that can be bad. If I do leave the ventilator in the room, I'm going to go ahead and pull it before the end of my shift and everything like that. The good thing about a lot of these modern vents is if the patient is end up having a little bit of trouble later on, I can use the same circuit and actually provide non-invasive ventilation instead of getting a standalone unit. So something to kind of consider, but clean up your mess for the next shift. As far as documentation goes, I would need to put a note in for extubation, document my assessment, my findings and everything, and usually most of our electronic charting, you're having to discontinue their airway, so make mention that you remove the airway in date and time. That should coincide with your extubation note. Discontinue ventilator orders, and put in any other new orders that you may have for that patient. All right. If there's other sort of problems that you kind of stumble upon as you're doing your assessment, you think they need other additional respiratory support, now they don't have that ET tube, be proactive, talk to your physician, get in bronchial hygiene orders, get them up and out of a chair, whatever they may need. Don't forget about it. Goes back to all the basic respiratory side of things, basic respiratory 101, general care. So one thing we didn't talk about is if they don't pass a cuff leak test, what to do. So let's say this patient has no cuff leak or less than 110 mil cuff leak. Got to have a conversation with the physician. I've worked places where they extubate anyways, all right, and just have everything ready to roll and all the appropriate personnel on hand. I've worked places where we give that patient some IV steroids, Salmeterol, and wait 24 hours. I've worked one place where they would extubate later in the afternoon if this is early in the morning after getting steroids, and then just be prepared for everything. It could be as simple as just having racemic epi ready or something. Most of the time we can get it very quickly, so I don't go through trouble to usually having that pulled out. It just takes me a moment from the Pyxis. So requires a conversation with the physician and coming up with a game plan for that. We wouldn't leave this patient extubated or intubated indefinitely, just if they continue to fail that cuff leak test. After we give them a little bit of steroids and time and everything, it's just we need to be ready for bad things to happen. So I hope that helps. Once again, we'll talk more about this from the lecture side of things. This is just a demonstration here. One last thing I'll kind of point out, I'm going to grab his old tube type stuff here and everything. If you noticed on extubation, I have a tendency to grab the syringe one-handed, holding the tube with the other, and deflate by pulling my thumb back on this and do it all one-handed. A lot of people struggle with that, and I go, I can't do that. If you needed to, just grab the tube and hold the syringe all in the same hand, and big deep breath in, all right, big cough out, and pull it, okay? So don't get tripped up and try and do my little one-handed finger flip here or anything like that. If it works for you, great, but if not, don't worry about that. The other thing I'd urge you to consider doing is take a look at the inside of that ET tube whenever you do extubate somebody. A lot of times you'll see biofilm and all this. And later on, we'll talk about some of the different things we can do to remove some of that biofilm from somebody's ET tube if they were staying on the ventilator for a period of time. So I hope that helps, and that is something that we'll continue to work on in lab.